I want to welcome everyone to today's question and answer discussion, little talk. I don't even know what to call it exactly, but welcome to the exhibit and to our conversation. So I'm Dr. Pam Schaff, and I'm the director of the HEAL program. And I welcome you to the Hoyt Gallery, where our HEAL program now has incorporated or started a mission to align the work of our patients, align the work of patient artists with the core medical school curriculum in the service of fostering enhanced understanding between patients and future healthcare professionals. As you probably saw last year, for those of you who've been around, not our first year students, who I welcome all of you, but last year we had several exhibits that were done by artists whose own experience with illness informed their art and whose work was shown in conjunction with our various organ systems. And we're continuing to do that this year as well. This exhibit is a little different. This exhibit really, I would say, crosses all organ systems and is about pain and the experience of pain, and Ted will be talking about that in a moment. I wanted first to introduce Dr. Sunita Puri, who is our Director of Palliative Care at Keck Medical Center. And in addition to being a terrific palliative care physician and educator, she also is a writer and has a book, a literary memoir that will be coming out in 2018. Is that right? Yes, we're very excited. And some of you may have seen her work in either JAMA in the Peace of My Mind section, or in the New York Times. She had a beautiful piece about a year ago that was about living and dying in Los Angeles. It was beautiful. I suggest it to those of you who haven't seen it. Doctor, sorry, I'm going to promote you.
My mother is so proud. I'm a doctor.
Ted Meyer is our artist in residence, and he has really transformed this space and our culture, and we're very grateful to him. And he's going to talk a little bit, but first I'm going to turn it over to Dr. Puri to talk about pain and its representation.
Thank you. I felt like we were unnecessarily far apart there, so. So thanks so much for having me, and I'm really here because in palliative care, thank you so much, Ted. In palliative care, we deal every day with patients' experiences of pain. And what I'd like to kind of offer in our, before we get into a more detailed discussion of the art, is the way that medicine has kind of lost its way with assessing and recognizing and treating pain. In palliative care, we generally see patients who are living with an advanced disease that at some point is likely to take their life. But I think that the framework we use to understand pain is something that I hope more fields in medicine will start to adopt earlier on in a patient's life, so that we are not waiting until they are living with a very serious illness to think about the many ways that people experience pain. The founder of modern hospice was actually an English woman named Cecily Saunders, Dame Cecily Saunders, and she kind of came up with a concept that we use in palliative medicine called total pain. Has anyone ever heard that term, total pain? Total pain. And total pain is the term she assigned to look to encapsulate all the many facets of pain that patients experience, not only physical pain, right? That's what many of us think about when someone comes to us and says that they're in pain. That's certainly a very big component of it in medicine, but physical pain almost never exists alone and in a vacuum. Why? Because physical pain greatly impairs patients' quality of life. And in palliative medicine, that term, quality of life, is something we use in almost every conversation we have with someone. Physical pain not only impairs quality of life, it does so because patients can't always do what they want to do, and their life is fundamentally altered by, for example, not being able to go to the bathroom by themselves because of pain. But part of the ripple effect of that is that there's other domains of pain. There's emotional pain that very closely interacts with physical pain. There's existential pain, and I'm curious how many folks in the room have heard that term, existential pain. Okay, it's totally okay if you haven't, but I hope what you'll take away from this is that existential pain and spiritual pain, which often go closely together, is a way that people experience a crisis of meaning in their life when certain things are taken away from them, or when they're living with a disease that alters their ability to be who they are in the world. So for example, I had a patient who was a painter who was diagnosed with MS. And for him, most of his identity was based on the ability to be a painter. And when he lost that ability as his MS progressed, when we talked about quality of life, he was like, well, my life was my art. What is my life now? And that's an example of existential pain, because it's looking at the very ways that your existence is compromised in the world when your physicality is compromised. So in our field, we're really looking at all those domains. We're looking at physical pain. Sometimes that comes from something like a cancer, which is, we see a lot of patients with cancer. Sometimes it's not just pain, it's shortness of breath for patients with heart failure or advanced lung disease. Sometimes it's nausea and vomiting, another very common symptom we see for patients who are getting a treatment that's meant to treat a disease. So when we talk about symptoms, including pain, it's not always from the disease. Sometimes it's from the treatment of the disease. We're also looking at emotional pain and existential and spiritual pain. And we also look at the pain of the patient's family, because most people with a pain experience don't exist alone in a vacuum. Their pain experience affects others around them, and that's something in our field that we take very seriously. So the patient is our patient, but the family and their experience of the patient and the patient's disease, they're also our patient. So when I'm looking at someone who's got pain, I'm really looking at the totality of their pain experience. And when I'm asking them how I can help them with their pain, I'm also asking what the pain prevents them from doing, which is not something that we generally ask patients. We ask about pain, we pull out a pain scale, or we ask them on a scale of 1 to 10, how would you rate your pain today? But I don't think that that's an adequate way of figuring out the impact of a pain experience on someone's day-to-day life. So when I'm meeting with them, I'll say, what is your pain preventing you from doing? Does it prevent you from doing really basic things? And if so, who's helping you to do those things? If we've given you a pain medicine, especially for my patients with cancer, we give them opiate medicines, morphine and its cousins. And sometimes the effects of the pain medicine make it hard for them to participate in their daily life. So there's physical pain, and then there's the impact of pain on other domains in someone's existence, including their family life and their ability to function. And sometimes it gets really tough because the ways we can treat pain can also compromise their quality of life. So it's not something that can be simply reduced to, here's a pain scale on 1 to 10, tell me where your pain is. That's simplifying a very complex human experience, and it's an experience that we will all have. And when you go through that experience, sometimes words and the questions we as physicians might ask may not be sufficient, which is why we turn to art, right? It's why we look to the humanities to help us understand human experiences that a certain cultural model of Western medicine may not give us the vocabulary to ask about or to really understand. So I think that's part of the reason I'm so excited to be in conversation with you, is to hear from you and your pain experience, and to hear about the ways that you have helped others kind of express their different types of pain visually. And I think the pieces that I've seen here have really struck me, not only because they're beautiful, but because they're all so very different. And I think that speaks to the way we experience pain differently and the way we communicate our pain experience differently.
Well, I'll give you first a little background on this show. We put out a call on several different websites. There's actually a big connection of male artists around the world, and there's several websites that you can post that you're doing a show, call for entries. And I just said, send us an image about physical or mental pain. something that you would like a doctor to see so they understand what you've gone through. Now, some of you have heard my story before. I was born with Gaucher's disease, so I had a lot of bone infarctions, bone crisis when I was a kid, and a lot of pain. So I sort of went into this project thinking, we're going to get a lot of images about physical pain because that was my starting point. And when the images started coming in, I was very surprised because almost half of these images are about emotional pain. If you go through and read, a lot of them have some text with them, but a lot don't. So that gets exactly what you're saying, that it might be physical pain that starts it, but what a lot of these people are writing about or sending artwork in about is emotional pain that goes with the physical pain. So within a span of about 2.5 months, we got 306 entries from about 18 or 19 countries, I don't know exactly, and everybody showed it a different way. Some are very literal. We have ones over here about migraines, but then right next to it there's one from a prisoner who murdered somebody and he has a life sentence, and you see his brain cracking as the calendar flies by him. So everybody's got their starting point of how they figure out pain and what most hurts them, whether it's physical or mental. So that gets us to a couple of questions. So I'm approaching this gallery art-wise and question-wise as someone who is a lifelong patient with chronic illness, but chronic pain. So a couple things that you alluded to, that 1 through 10 chart. I always remember getting those little faces with a smile. Can you really tell that much from that? I mean, they're not very specific. You know people are in pain, but what do those really tell you? What will it tell them as future doctors?
So I actually don't use that frowny face, smiley face approach to pain because I don't think that gets into the pain experience, right? Like someone can tell me their pain is a 6 out of 10 and yesterday it was 10 out of 10. What I'm more interested in is what can they do now that their pain is better controlled? Because I always relate it back to quality of life and the way that a pain experience may impact that. So I think there's some value, maybe in some circumstances, around asking about using a scale. But in my practice, I actually do not use that. And I don't know many palliative care physicians who do, because our take on pain relates entirely back to quality of life. And I think it's, again, a reflection of how we in medicine want to capture things on something that's validated and knowable in a very specific way. Like 6 out of 10 is better than 10 out of 10. But at a 6 out of 10, are you able to go to the bathroom on your own? That's what I'm interested in knowing. And that's where I think those scales are not sufficient. Maybe they can be a part of a larger pain assessment, but I also think patients have a hard time telling me a number. They can tell me my back still hurts and I still can't get out of bed, and that tells me a lot more than maybe the pain is a 7 instead of an 8. Does that make sense? Okay.
Okay, so one of the things with my illness, and so when you have bone infarctions, or at least with my illness, the bone is dying, it's swelling. It is extremely painful, and I've spoken to a few women that have my same illness that said it's sort of comparable to childbirth, and you always hear how bad, that's sort of the top bar. Childbirth is the worst. Yet people do it over and over again, and I know in my case, when I would have a bone crisis, it would be so painful. But the second the pain went away, I could not even imagine how badly it hurt until I had the next bone crisis, and then I went, oh, that's that pain that was so horrible. So maybe you could talk the mechanism of how pain works and the fact that women will time and time again do something so painful because they can't, maybe the love of children, or maybe because the brain sets it up that you cannot remember how utterly painful something is. So you do it again.
So that's a really interesting question. And I think From a medical standpoint, there's different types of pain. So there's, and I don't know how technical I really want to get here, but there's pain that can be caused by a direct injury, and we call that somatic pain. It's mediated by a certain path of nerves. There's visceral pain, which means kind of like crampy internal pain that can be related to a lot of different things, but it's more experienced as dull or achy. There's neuropathic pain, which is something that's mediated by injury to the nerves, and that's experienced as kind of a burning and tingling. And bony pain is actually very related to inflammation. So sometimes really simple medicines like ibuprofen or steroids can be super helpful for that. And I think when people choose to go through or choose to engage in activities that may trigger pain again, I think that it's really because there is a sense of fulfillment in whatever that activity is. We have great ways to keep pain under control, but sometimes, like I have many patients who find it very painful to do certain things, but even when I've got them on a pretty good regimen, but they will still engage in those activities because of the emotional or spiritual or existential meaning that those activities give them. I do think when people are doing something that means a lot to them, even when there is pain involved, we have some way emotionally to push through the pain. And that's kind of a complex set of mechanisms, but I know that they exist, and I think that's probably why women go through childbirth again and again and again. Not having been through it myself, but knowing many people who've gone through it multiple times, that there's something in the pain and about the experience that pain is a part of that is bigger than the pain itself, if that makes sense.
So I'm curious more in the idea that the brain can't remember how bad it is. Mm-hmm. You know, like if there's a defense mechanism, or at least seems to me in my case, that I can sit here and think, I had severe pain as a kid, but unless I have another bone crisis, my brain can't remember that pain as severe as it was.
I think that's a survival mechanism, because if people remembered the intensity of their pain, and some people do, so I think there's a lot of individual variation around that, but I've had patients come in with a really severe cancer pain crisis, and we get them better, and some really fear it, like it lives in them, the fear of that happening again. Others are able to put it behind them, and when the next time comes around, it's as if they've never experienced it before. So I think there's a lot of individual variance in terms of how people cope with it, and how they push through it, if that makes sense.
Now, I remember, and again, sorry to keep bringing this back to me, but that's where I'm starting from. So I had such severe pain as a kid that I could go to the dentist without anesthesia or something. That was low amount of pain. But now I would never do that because I haven't had a bone crisis in 40 years. So is pain something that you can build up a tolerance to? Can your brain shut it down? You know, like now I would never do something like that.
I think that, yeah, there are mechanisms by which that does happen. Yeah. Okay. Yeah, it's very individual though, right? And I think it's not just something about biology and neuroscience, it's something that has to do with the emotional coping around it as well.
Okay, so last question for all these guys that are studying, and they're going to have patients that are going to come in that might look fine to them, yet the patient will say, I've got this debilitating pain, but it's not like a wound, you can't see it. So how do they keep their compassion? How do they keep that when dealing with the patient and try to have this empathy for patients that they can't really see the pain and deal with it and be good doctors?
So I think that's a very important question, especially now, because we're kind of in the midst of a lot of coverage on the opiate crisis, and doctors are having more hesitation in prescribing medications that maybe 10 years ago were given out perhaps a little too freely. But I think remembering that pain is kind of a vital sign that we can't measure numerically, but we can have the skills to ask about how pain impacts someone's quality of life. And even though someone, and I see this every day, where someone might not look like they're struggling in a way I would imagine them that struggling would look like, they still are struggling, and it's our job to listen to them and understand how much of that is physical, how much of it is emotional, and knowing that those two almost always interplay. My suggestion is always to remember that even the things you can't see, which is a lot of things in medicine, are things that are real for people. And asking about the impact of pain or other symptoms on people's quality of life, I think is a way to really understand from a daily activity perspective, what is their symptom preventing them from doing, especially things that bring them meaning. So please take seriously the things you cannot see, because I think that's a lot of what we deal with in medicine. It's not always going to be a big gaping wound or a broken leg that, you know, are the things that we see that constitute pain.
So if any of you have any questions, come up to the microphone here.
You mentioned that you are asking the patient what is preventing her or him to do because of the pain. What happens if come in front of you a patient that has a very high tolerance for pain? And nothing is preventing them to do, but their pain is very, very severe. For instance, my daughter, she suffered from WPW and she had a severe attack. Her pulse was somewhere there. And when she came to the triage, she was told to go and sit down because she looked normal. Now, her brother is a doctor and he came after her. He came to the window and he said, that one has high. Immediately she was pulled in because when you looked at her, she didn't look with pain, even though she had severe pain. Now, when her doctor saw the chart, then he asked her, you want to tell me that you walked and talked at that situation? So she was able to walk and talk, because if you ask about the pain, in that kind of pain, people usually are already comatose or fainted or something like that. She was able to walk and talk. So sometimes it's not an indicator.
Certainly not, and I appreciate you sharing her story. What I was trying to say is that we do ask about the ways that pain impairs quality of life, but sometimes it doesn't, right? Sometimes people really push through it, but you should still ask them about their pain experience and treat it. So yeah, I'm glad she's okay.
I appreciated you mentioning emotional and existential pain. It made me think of the Holocaust survivor Viktor Frankl, who had a term called logotherapy about meaning in life. And I'm just wondering how you see future physicians, how they can collaborate better with mental health professionals and other allied health professionals in dealing with those elements that contribute to pain.
I think every good chronic pain team needs a pain psychologist. I think that's actually standard of care. So anybody coming in for a chronic pain evaluation, which is different than a palliative care evaluation, just to be clear about that, chronic pain patients are patients who are expected to have a longer time to live than the patients that we generally see. But on any chronic pain team, they definitely have to have a psychologist. And I think that's really important because emotional pain is a really big part of physical pain experience, and emotional pain even on its own, even if someone doesn't have physical pain, is something I don't think we treat well at all in our country. And I could go on about our lack of mental health resources and the ways that the need for that is still very stigmatized. But to keep it to discussions of pain, I think it's an integral part of teams. And teams that don't have a pain psychologist, chronic pain teams, almost always make a referral if they don't have someone on staff. I know our team at Keck does have, I think, 2 pain psychologists, and I think that's integral. I also think social workers for support and for therapy are really important. Sometimes we manage emotional pain with medications, and I don't think that's sufficient. I think that people actually need to be able to talk through their experience and not just be handed a pill. What's difficult is that we don't have the resources as a country to meet all of those needs, and I really hope that that will change in the future. My brother is a psychiatrist, so he sees it all the time, and he knows how stretched thin they are. And he also complains endlessly about how we don't have those resources, but I think they're really important and essential, absolutely essential. The other thing I will say is around existential and spiritual pain, that the use of chaplains and folks from different people who have a strong faith background can sometimes find ways of coping that are spiritual. And so I think especially when patients are in the hospital, making sure to refer to chaplaincy if some of what they're experiencing are questions like, why would God do this to me? What meaning does my life have if I've lost certain abilities because of my pain? I think looking to chaplaincy is hugely important, and for all the medical students in the room, I would make sure that you remember how integral they are to the care of patients and to the really comprehensive care of patients.
One of the side effects of Gaucher's is there's a higher percentage of people with Parkinson's, and my brother developed Parkinson's from that. And I found that his line kept shifting of when he was, there's that point, I don't want to live past this point. But then it kept shifting, and when he was way past that point, he kept sort of moving the bar. I don't know if you have, is that a normal,
Yeah.
you see that a lot with people?
I think, yeah, that's very common. I think that there's only a handful of patients I've seen who have said, if I cannot do this, then, I want to change the course of my treatment plan. Because I do think it's not that easy to say. Like, I could say, if I couldn't do X, Y, and Z, my life wouldn't have meaning. But that's a really complex set of things that come to bear on a decision like that. I've seen many patients who can't do certain things, whose life they believe still has tremendous meaning, because our lives are about more than just the things we can do. So I think it's not uncommon for people to keep reassessing what brings them meaning and what is too much pain for them, which is why we have not just one, but kind of an ongoing conversation with them about what matters to them most, especially in our population when we know patients are living with a life-limiting illness. But I think for anyone with a chronic debilitating illness that causes tremendous pain, that checking in about goals and quality of life should be part of our vocabulary for all physicians to be asking about.
Thank you guys for talking to us today. As students were taught in our patient interviews to use the 1 to 10 scale and have that little picture chart, I was wondering if you have any examples from your practice of questions that you ask patients to better understand their pain experience.
So certainly, I think there's a whole set of questions I could go through, but talking about where the pain is, the quality of the pain, all of the things you're going to be taught, but I'll continue to hammer home the question about quality of life and to ask, what are the things that your pain experience prevents you from doing? What kind of assistance do you need to do things that you wish you didn't need? I think that you really want to establish how the pain affects someone as a person, so that you're not just looking at medicines to help them, you're looking at other ways that they can be helped as well, whether it's an assistive device, whether it's physical therapy. You need to understand the way it affects them globally, and not just, I have back pain, that's a 7 out of 10. So I think asking specifically, tell me the ways that your back pain affects your daily life, and getting really specific. Do you need help getting in and out of bed? Do you need someone to help dress you? Do you need help to the shower? What do you do for work? You're a bus driver. Is your back pain preventing you from taking your normal shifts? What have you done to address this? So putting the pain into the context of their life is, I think, my very, very big suggestion.
Thank you.
I was wondering, do you treat children and elderly as well? And if you do, are there any unique things about the history taking that you make sure to touch on for differences that they have?
Yes, there is pediatric palliative care, and I think many of the questions we tend to ask are the same. Sometimes it's very difficult with young children because they're not always able to verbalize their experience, so we kind of look to the parents more, but many of the questions are very similar. And certainly for elderly patients, some of the questions I just said are really around activities of daily living, ADLs, and IADLs are independent activities of daily living, so we ask a lot about really specific things that pain compromises.
Thank you.
Yep.
What are some good ways for us to try and relate or express empathy towards people who are feeling pain? Just because as students, I'm either torn between saying something kind of disingenuous like, I'm sorry, or I can't imagine what you're going through. Or I've seen, a lot of students will say, oh, I know what that's like because I blah, 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 and you start talking about yourself. So what tips do you have about that?
I'm happy to give my response, but I'd be interested to hear from someone who's kind of had this experience.
No, let's hear yours first. I want to hear yours.
No, let's hear yours first.
Well, so one of the projects I've done is lots of people's stories about their scars. I have a whole, like 100 or so people that I've listened to their stories. And that's something that pops up a lot is they get very angry when they go to doctors and the doctors try to equate what they're going through in treatment to something that happened to the doctor. And I understand that a lot of times the doctor is doing it to be empathetic and say, I understand what you're going through, but because of the other things, the family dynamics and how long you've had it, so I don't really know. I mean, it's you guys are kind of in a no-win situation here. I think it's just a matter of listening and, like you said, then bringing it back to going, well, how is it affecting your whole life? I don't think you can ask too many questions about how it's affecting the general life of the person because, as you said, some people are going to have a really high tolerance for pain and something might not affect them, but then somebody who's led a pretty easy life and never been in a lot of pain can be really thrown by a much smaller amount. So I think it always gets back to this, how is it affecting your life in general?
I'm going to take first crack at a physician answer also and a patient answer. I just think, as you've been speaking, I've been reflecting on my own experience as a patient, and I am astonished, as you've spoken, that it really is only the physical therapists who ask the kinds of questions that you're talking about. And I know we've had a conversation many times about medical education and about palliative care really needing to be considered an aspect of primary care. And when we think about pain control or pain management, certainly, or just pain conversation, there is no one who has asked me those questions other than physical therapy. And there's something wrong with that. And I think that in answer to the question that was just asked, if we can train students and trainees to better ask about the effect on any individual's life at any given moment in time, we'll do a much better job, I think. So.
And I think, when you're students, just thinking back to my own student days, empathy is a very tricky thing. I suggest you all read an essay by Leslie Jameson, who is a friend and a really amazing writer. She's an essayist. It's called The Empathy Exams. And she has an essay collection called The Empathy Exams, but the title essay is about her experience being a standardized patient for medical students. And it kind of weaves in personal narratives as well, but it's about the ways that she is asked to grade people, medical students, on their performance of empathy when it may not be genuine. And she's really kind of circling around what is empathy. And she describes empathy as a passport into someone else's experience. I don't think there's one way, right, to be empathic. I actually think the cornerstone of it is listening and really being open to someone else's experience and making sure that you understand it. I think it's fine to say things like, I'm so sorry that you're suffering with this. I really want to be of help. It really depends how much you want to say things like, I've been there before, because you don't want it to be about you. And I think there's ways to relating to a patient's experience that come really back to making sure you understand the experience. And that means listening and asking the right questions. And I think tone of voice and manner and giving space for their responses are all interpreted as empathy and compassion.
So I want to talk about a few of these postcards, and then you guys can walk around afterward and see them. I'll let you comment on these. So this one just says arthritis on the front.
It says arthritis, and you can kind of see a really shadowy figure of somebody who looks like they're screaming in the background. The way I kind of look at this is that arthritis can be a really isolating experience, I think especially when people lose their mobility, that they're not always seen in the ways that they hope they would be seen. And I think arthritis pain compared to things like cancer pain does not always get a spotlight shined on it. So what I see here is somebody that really who wants their pain experience to be seen and whose suffering is really kind of shadowed. If we're looking at this picture, I mean, we don't see a whole lot of detail other than a really kind of faint suggestion of extreme pain. And I think that says something very powerful about how this person feels she's seen and possibly how her pain has prevented her from being seen.
That was great. The LA Times needs a new art critic. So. All right. All right, we're going to trade you here. So this is one of my favorites, this migraine one.
So this is very, very powerful. And it's kind of, this person's face is kind of squished between two, I'm not sure what. Vices. Yeah, vices. And that's all around it are the words stress, mental illness, death, depression, suicide, pressure, Alzheimer's, and cancer. But clearly the pain and the other issues that are written around here are kind of squishing this person, possibly not only to the point of worsening pain, but possibly to invisibility if you continue to squash. And I think it kind of illustrates also that pain is not just physical, because some of the things on here like depression, mental illness, stress, pressure, death, these are not things that are necessarily physical experiences alone, but they're things that could be compounding another illness. So it's a very powerful image.
What's interesting, I know this woman's work, she does a lot of portraiture, and it's always very happy. And when this one got mailed in, and I saw the style it was painted, and I was really surprised that, and I haven't talked to her saying whether this is a general image or specifically about her yet. So when I find out, I will let you all know. So we talked about this one a little earlier. Here, I'll let you hold it up. So this one seems all cheery and happy, but it's about someone having celiac disease.
My eyes went right to this because there were donuts on it, so I asked about this one. I haven't had a donut in a long time, but anyway. So this I thought was so interesting because you need a little bit of context to understand it, but also because you can kind of impose whatever your experience might be onto this. I know Dr. Schaff had mentioned that maybe the pain of not being able to eat these, or I forget what exactly you said.
Yeah, so donuts are just awesome, and I want them, but I won't let myself eat them. So I was thinking, this is somebody who thinks, I just really want that. So I mean, in a way, it's somebody who can't eat them. I just won't allow myself to eat them.
Precisely because if we didn't have pain in here, it's a really cheery, happy, Homer Simpson-y image. It's especially strong because it really makes you stop and think, what is this person trying to communicate? And the fact that they have celiac disease, I think it's not specific to donuts, but it's, donuts are an everyday thing that you see at nurses' stations. People bring them to meetings, and people show up because there are donuts at a meeting and so forth. So it's something that's so everyday to the rest of us, something many of us can eat without thinking, but for someone with this disease, having donuts at a meeting is a reminder of the one way they can't participate in the life that other people have access to. And so I think it is pretty emblematic of something like, I take for granted walking around here, but someone with arthritis, that's a big deal for them. And so I think everyday things that are not accessible to others, it's a part of a pain experience, which is why I think it's especially strong.
Now, the last one, I don't know what to make of this last one. So there's a few artists that sent us over the span of a month several pieces. There's down here, there's 3 that look alike. They're from a woman who lives in Michigan, and this is a guy who lives in England. And if you look around, you'll see there's another piece on the back, and it's just this weird marking system. And they look very disturbing to me, but I don't really know how to interpret them. But there's a book over here he did, there's another piece over there, there's one over there. So like about once a week, I would get an email from him, and they were sewn together and sent out like this as a book. So I'm just going to let you take a crack at this since you're now the LA Times art critic.
Yeah, and this is one that kind of, to me, looks like there's something potentially orderly here, almost like a pillbox maybe. It's like a rectangle with a bunch of circles, and then there's chaos around it. So I almost wonder if what he's trying to communicate is the chaos of his experience superimposed on something that may be a tool to help him manage it. I don't know for sure, but when I'm looking at it, chaos comes through, which I think is really common to people who are suffering in many different ways. That there might be a way to help them, but superimposed is all kinds of other things that are hard to even make into shapes. Like sometimes there are no words for an experience, sometimes there are no shapes to put on a page.
All right, do we have any last questions from any of you future doctors? How about a comment from you?
Well, I just want to thank both of you for your perspectives and for a great conversation. You really made me think more. Every time I come through here, I try to look at a few of the pieces, and they're so rich, and there's so much conversation that we could have around all of them. So thank you for the little taste, and I would encourage everyone to take some time to wander and maybe, how is our time? So we have 10 minutes. I'm not sure when classes start or where you need to be, but Ted and Dr. Puri can stay for at least a few more minutes if you have questions about any of the art or any of the things that we talked about. And I thank you all for coming.